Hello everyone, it's Dr. Zizzy again. Hope you're doing well today. It's again a lovely day here in Morgantown. There must be something about the times I choose to record my audio lectures, but um, it's a lovely sunny day, so I hope it's the same way in your summer. I do apologize again in advance if there's any sort of interruptions. If you hear a phone call or a knock at my door, I'm recording this in my office, so I will take a quick pause and then, of course, get back to the lecture. In this second unit, we'll be looking at some of the more clinical issues related to the psychology of injury, and those include several topics that we'll have a look at. What you would be considered a normal response versus a dysfunctional response, how to identify whether or not something is a clinical issue versus something that's just a normal thing that's occurring to an athlete under stress, and in this case particularly, an athlete, the stress that they would be experiencing relative to their injury. After that, we'll look at some specific psychological issues for injured athletes, including adjustment problems, depression, anxiety, and eating disorders. We'll also look at pain management, which is a critical issue for any injured athlete. And then we'll also, at the end, look at, well, how do you make referrals? So much of this language is useful for sports psychology students and sports medicine students, such as those in physical therapy programs or athletic training programs, with the understanding that you may or may not be the person who would provide the psychological assistance to the athlete, but you do need to be trained to identify whether something is problematic or not, and then what to do when that occurs. Let's get after it. Although we're really going to focus a lot on the counseling issues, the pathology, the things to do when things go wrong, one caveat is that most athletes, probably 80-90% of them, do fine after a couple weeks. They may have some stress from the injury, they definitely don't like it, they have to manage pain, they might be a little bit down, but the majority of athletes react and cope fine with injury, and a few will struggle. And so we want to start this with the idea that psychology of injury is not a grim tale that every athlete who gets injured doesn't cope. In fact, athletes are pretty tough mentally. They're pretty tough physically, and they respond a lot better to injury than would someone, for example, in a physical therapy population or a 58-year-old person who had hip surgery, something of that nature. So sports psychology is actually a great fit for this because we really don't focus as much on the clinical, and we focus on strengths and weaknesses. So let's look at where to keep our minds. As we move on and start to assess clinical issues, one thing we want to keep track of, and this is for athletic training students, sports psych students, is that our job is really a supportive personnel in this process. And so in that case, it is our job to keep people accountable to the goals of rehabilitation. So if we catch people coming in with a negative attitude or thinking patterns that are totally not rational, then we need to help them and remind them of, wait a second, this is not the worst possible thing that it could have happened. This is not a catastrophe. It doesn't matter whether it's fair or not. And I do really encourage you to check out the Fisher and Risberg article. It's called The Zen of Injury Rehabilitation. It's a short article that I think you'd find very interesting that looks at some interesting perspectives and a different philosophy on that athletes could adopt going through rehabilitation that helps them get over that. If we catch athletes not putting much effort into rehabilitation or avoiding it, then we need to call them on that and say, hey, that's really their responsibility. And if, for example, you're an ATC, you can't really help people if they don't show up and if they don't put any effort in. You can't do the leg extensions for them. You can't make them work out their shoulder. They need to be held accountable for low effort and not be acting like a patient or a victim. They need to attack their rehabilitation within the proper limits. Another thing is somewhat difficult is to identify if the athlete's getting secondary gain from being in the training room. And might be classified as a malingering athlete, or an athlete that is just trying to get out of heavy preseason training, for example, or they're getting more attention in the training room, so they spend a lot more time there. So we do need to be aware of that. And as a helping professional, that can be a tricky pattern to try to recognize. There's some good information on your text on that as well. And ultimately, a lot of athletes might complain about how fair it is, why did this happen. It doesn't really matter. It doesn't matter if it's fair or not. Life is not necessarily set up that we get an equal share. That's why some of us grew up in the United States in fairly well-to-do families and plenty of opportunities, and other people may have grown up with in a very poor family or with not even a full set of parents or a real family. So it's not an issue of fairness. It's an issue of controllable and uncontrollable. What can the athlete control? What can they? So that's really our job, is to help with the overall attitude and approach to rehabilitation, whether you're an ATC or a sports psycho. Some normal things that you should see, and I do disagree a little bit with the textbook in this area, is that it's normal to be angry, confused, and frustrated, whereas your textbook says that that's a warning sign for maladjustment. To me, that's totally ridiculous. If you've ever been injured yourself and you weren't angry or frustrated about being injured, that would be a strange sign, in my opinion. It's good. It's okay to be discouraged, mildly depressed and down. Take for example an athlete that was training all preseason, all summer to get ready for their sport, and they get injured the first or second game or competition in, and they might be out a couple months. So now they may really feel like that's wasted. That was time wasted in the summer, which it wasn't, but it's easy to feel that way, like, why did I do that if I was just going to get injured? It's also normal for athletes to deny their injury, say that it's going to be okay, say that it's going to be fine, and really just want to know when they can get back to competition. They're athletes, so they want to get back typically. If they don't have some of these things, if they don't have a desire to compete again, if they're not at all down, or they're in total denial and have extreme responses, then that's not a good response. Another common thing you'll see in the first couple weeks would be concerns over pain management. How do I deal with this? And then, boy, I don't want to lose my conditioning. So in any sport where conditioning is critical, which is most, but particularly any of the endurance events, there may be some issues there with not wanting to take time off because they're already in a high level of fitness, but in reality the injury may warrant that. So those are some fairly normal signs. Let's have a look at some areas where they may be showing problems. And you can even think of these issues as a checklist for yourself. And there is in the Taylor and Taylor book, if you happen to pick up that book, a checklist of psychological distress that includes these, some of these issues. And basically a lot of these warning signs are extreme responses and extreme versions of what you would have seen in the previous slide. So being totally obsessed or having a total loss of interest could be signs of problems. Over adherence or doing too much rehab in an effort to try to get back, because they're impatient, could be problematic. Or the flip side, just totally not showing up to a lot of rehab. If you have an athlete that socially withdraws for more than a week or two and folks can't find them, they're not using their social support network, that can be really a poor sign. If they start to self-medicate with either prescription medication, alcohol, other recreational drugs to deal with depression and anxiety symptoms, that can be problematic for obvious reasons. If they start to be concerned about body image, weight issues because now they can't get in the level of training that they would like to get in, that could be problematic. And so some of these signs, it's not to say if they had one that all of a sudden you need to call a psychiatrist or something, but you do need to be aware of these issues and have an open dialogue and hold athletes accountable. So if I was a sports psych person working with an injured athlete and I found out they had missed, let's say 3 of 5 rehab appointments over a couple days, then I'm going to find out what's going on. I'm just going to call them to the table and say, what are you doing? You told me that you wanted to get back for X, Y, or Z, whatever event, and you were highly motivated, but you're not showing up to rehab. What's going on with that? So it's our job as a support personnel, be it a coach, an ATC, a sports psychologist, to hold folks accountable to their attitude, their approach, their effort towards rehabilitation. Because ultimately, as a sports psych person, we do not design the rehab program. We're not the coach. So we can be helpful in a different kind of way. So you'd want to check to see these and then how severe and how much of this stuff is happening. We're going to look at a few of the most common psychological issues that occur in injured athletes and spend just a couple minutes talking about those issues. And this is stuff that you won't see as much in your text, but it's useful for anyone that's working with injured athletes to be aware of some of these issues. Flipping back for just one moment, anytime you're trying to figure out from a psychologist kind of perspective, is this something that is just a concern or is it a clinical issue? There's a variety of questions that you can go through when you're working with an injured athlete, or any other athlete for that matter, to determine, is the athlete clinically depressed or are they just feeling down? And as you may imagine, there's a set of guidelines to determine, okay, yes, this person's clinically depressed, so therefore they can be medicated for it, or no, they're just experiencing a depressed period or they're down. Yes, this person's experiencing anxiety, or are they clinically anxious? Okay, so we're going to look at some of those questions. Let's start at the top here, looking at just this first question up here. How long has this problem been going on? Well, the length of the issue, typically if it's an injury onset, you could expect athletes to experience a lot of this negative mood for about 2 weeks. So that 2-week period is approximate. You might think of it as 1 to 3 weeks, but it's a useful frame of reference. Like, okay, let me give this athlete a couple weeks, or give myself a couple of weeks to adjust, and maybe be down, maybe not want to feel like going out, maybe feel a little bit anxious or pain. And in addition to that, how long it is, the type and severity of those reactions. So if an athlete was experiencing severe depression for 2 weeks, that might be very unusual. If they were experiencing moderate depression or anxiety, okay, that might be fine. As I mentioned on a previous slide, is the athlete socially withdrawn or not? Are they avoidant? And how does that match up with their personality? So if an athlete's typically extroverted, life of the team, and now they're not, and they can't be found, then that's somewhat of an unusual response. If they're somewhat of an introverted person and doesn't go out anyway, and now they flip on that and now they're going out downtown all the time, that can also be problematic. One key issue that you want to be aware of, if the athlete's depressed and they start to, their self-talk starts to have some of this, you need to tune in a bit, because there may be other things you need to do. So if they're feeling hopeless, like there's nothing they can do, they're very depressed. So if they have severe depression, you really do need to pay attention to figure out whether or not they have a plan to harm themselves, and they have any sort of what we would call suicidal ideation, which we'll have a look at. As I mentioned before, any dramatic change in behavior is cause for concern. And if an athlete, let's say you were working with a cheerleader, a gymnast, or another athlete that typically takes care of themselves and has good personal health and dresses up and wears makeup and wears nice clothes perhaps, and now all of a sudden they're totally disheveled, they don't maintain their appearance, they're wearing track suits when they wouldn't normally be, they're not taking care of their hair, or you have another athlete that's not shaving, take a man that's not shaving, they're just letting stuff grow out, and maybe even when they have to do presentations or other things. So if they're not maintaining their personal health, that's a sign of poor mental health. Also, are they coming to early rehab sessions with the smell of alcohol? Are they clearly hungover more often than not? Is there any other signs of substance abuse or compulsive behavior? Now, one thing I want to spend just a couple minutes on, in case you have to deal with it, is the athlete suicidal? Now, as I mentioned at the start of the lecture, this doesn't happen that often. And I usually tell the athletic trainers that I work with that they might only have to deal with this once every 5 years, once every 10 years. It'll be a day that you clearly remember. I've been working at WVU now 10 years, since 2000, and I've probably had to deal with this 2 or 3 times where I was working with either a student or an athlete that I thought was potentially suicidal. And so I'm going to walk you through some of these questions here that you need to have in your head that you may even need to ask the athlete that you're working with to figure out whether or not they're actively suicidal, which would mean you need to get them to a hospital as soon as possible and get them under the care of a psychiatrist, or are they passively suicidal, meaning they're very depressed and they have had thoughts of suicide, but they're not intending to act on it immediately. Okay, The first is the intent to harm. They may express that in a passing thought, yeah, I was thinking about hurting myself, or yeah, I have had thoughts or dreams. Unfortunately for you as the helping professional, now you need to find out more about that. So you need to find out if they have a specific plan. It sounds a little morbid, but you need to ask them whether or not they've thought about how they would do it. Now think about it for a second. Why would I want to know whether someone wants to jump off the Star City Bridge or they want to shoot themselves? Why would I want to know that as a psychologist? Basically, I want to know if it's available to them. So if an athlete tells me, let's say there's a, and the stats on this, just so let me back up just a second, is that men tend to choose more violent methods to try, and women tend to choose less violent methods. So women try more but succeed less. Men try less but succeed more. So, for example, a guy might be more likely to use a shotgun, and there aren't too many failed attempts when you point a shotgun under your chin. Whereas a woman or someone else may choose to take a bottle of pills, and then they pass out and they make it to the hospital and get their stomach pumped. So I want to know what the specific plan is. So let's say you're working with a client and they would just overdose on their sleep medication. They would take the whole bottle. I might ask them, well, how much do you have at your house? And they might say, well, I've got 15 or 20 pills. Okay, well, I'm not letting that athlete go home, because now all of a sudden I'm responsible for that. So if they have the means, which would be the pills or a weapon, and they do intend to go home, where they have access to that, no, that's not going to happen. So you're going to call the nearest emergency room, you're going to call your supervisor, and everything's going to hit the fan for you that particular day if that occurs. That person can't leave your site. Now, you're not going to forcibly hold them there, but if they have a specific plan and the necessary means and they do intend to harm themselves, then you need to escort them personally to the local emergency room or to an outpatient psychiatric facility. Okay, and you need to call every boss you've got and light a fire under their butt and say, I need your help right now, if that occurs. There is some literature in terms of history of suicide attempts. If they've tried before, you can ask them that, hey, have you tried before? And that behavior does predict future behavior. I would say commonly suicide is thought of as a cry for help, which can be true, but it's often also just simply an attempt to gain control over a life that seems to be spinning out of control, or feel helpless. And that's why on the previous slide, if you're hearing athletes talk about how it's not really worth going on, it's not worth living, then you need to really be paying attention to that, and then maybe ask them some questions in a confidential way if you can. Hey, have you had any thoughts about hurting yourself? A lot of times they'll just lay it out there for you when they're ready, but and if they haven't, they'll say, oh, no, I haven't really thought about that. Okay, then you just need to, you'll be glad you asked the question. Okay, so you do need to go through some of these topics, and mostly for athletic trainers, sports psych students who might become counselors, you'll get well trained in this area, but athletic trainers, you may not. So those moments where someone reveals it, you need to go towards them as opposed to avoiding what may be a very uncomfortable topic for you. So I hope that makes sense. And anytime that you are in one of those situations, you're certainly welcome to call me here if you're on campus, or you're welcome to call anyone else that you have access to and get some consultation on that as soon as possible. Okay, let's move on. One of the more common issues that would be classified in psychology is simply just an adjustment disorder, meaning that you have trouble dealing with something specific, and it's occurred within 3 months of that. So you could even have an adjustment disorder as a freshman student, like because you're having major league problems transition, living out of the house and dealing with school. And you can see there's a fairly low number of athletes that report clinical levels of distress, including depression, anxiety, and some of these other issues here. And so this is the thing, the hallmark feature of an adjustment disorder is that you are reacting to some specific event or transition that's occurred in your life. And you can have that with depressed mood or with anxiety. So that's a fairly common diagnosis for an injured athlete who's just the onset of their issues have been since the injury. Clinical depression is kind of a subcategory there. And you can see some of the stats here about how common this is. And a lot of people do suffer from depression, and some of the most common reactions are symptoms you see here. Loss of energy, loss of interest, changes in sleep. And this can really have an effect on injury because the lack of quality sleep and rest will actually disrupt your immune system. There's been some research with football players showing rates around 10 or 11%. So again, you're not talking about a large percentage. So even though we just got done talking about depression and a very serious issue, I want to be clear that this is not something that happens a lot around here on campus, among college athletes, among high school athletes. It's simply not. But you do need to have the training in sports psychology to recognize the difference between someone who's clinically depressed and someone who's just down. And that's a really critical clinical skill for all of us to have in sports psychology, and then also to help train sports medicine professionals to be able to recognize that as well. Some characteristic features, one way that always helped me remember depression was this acronym called SIG-E-CAPS that hit all of the hallmark features of depression, affecting sleep, interest, experience of guilt, lack of energy, disruptions in concentration, changes in appetite can go both ways, feeling sluggish. One of my favorite words in psychology here, psychomotor retardation. So basically just means that you're very sluggish and you don't have a lot of physical activation, which obviously for an athlete who needs to train, needs to do rehab, not a good response. And then there may or may not be suicidal ideation as well along with that depression. So hopefully that can help you remember those. Anxiety disorders are another common issue. And they're not as common as depression probably. And adjustment disorder will be most common in that area. But there's two features of anxiety that are critical to understand, even if they're not clinical. And these are the features at the bottom of this slide right here. So when a person's experiencing anxiety or fear, then they will typically avoid whatever it is they are worried about. So for example, let's say you're scared of spiders, simple phobic kind of response. You don't look for spiders. You don't want to go places where spiders are. If you see spiders, you run away. So if you are afraid of the pain of injury, if you're afraid of the idea of returning to sport, then you will struggle to show up at rehab. You don't want to be at practice. You will avoid it. Okay? You will avoid those settings in which the anxiety is occurring. So, that may be one of the reasons the athletes don't show up to rehab or don't show up to practice. They might avoid teammates. They don't want to talk to them because it reminds them of the injury. Anxiety also will impact your concentration and then your healing rates. So if you're having a lot of tension, and physiological responses are you have muscle tension and it results in guarding, it will actually increase pain, and it will also continue to tear down the muscles and the tendons going on because your sympathetic nervous system is always firing. So you have excessive cortisol in your system, which basically is a catabolic hormone that breaks down everything in your system. So it's counterproductive in terms of healing. Okay, so even if an athlete does not meet the criteria for an anxiety disorder, it just still may be a useful thing for you to pay attention to as someone working with injured athletes. Briefly mentioned substance-related disorders. Really, in injured athletes or in athletes a lot, it can be a common behavior in college students, obviously. And the issue is then, are they abusing it or not? So if it's an issue of abuse, certainly it's occurring frequently during the week, and then also they're suffering consequences related to that abuse. So students that are missing classes and exams and work related to substance use, like drinking, for example, that's a problematic behavior. And that could mean they have a substance-related disorder. Typically for injured athletes, they might be using a substance or abusing a substance just to deal with pain or anxiety. So athletes might smoke up to deal with anxiety. They might drink to deal with depression. They might just deal with the emotion of the injury through that. And that would be a passive coping style. That's what this refers to on this slide. Versus active being attending rehab and dealing with the consequences of injury. when you have substance abuse, it does disrupt your sleep, and it will interfere with the body's healing mechanisms as well, so it can kind of be a double problem. Now, a little bit on eating disorders. It's useful in this topic, simply in this lecture, because it's related to clinical issues, although it's not that common. There's not a lot of literature out there to suggest that injured athletes develop eating disorders, but it's a useful time to talk about it. There is an assumption in the literature that athletes are more likely or at higher risk for eating disorder behavior than non-athletes. We're going to look at the next slide in a study about some colleagues of mine to see if that's true or not. But instead of thinking of this as athletes either having an eating disorder or not, you should think of it really as a continuum, from 1 to 10, from very severe all the way back down to very mild. Because some athletes, some training sports, the eating patterns are just strange no matter what. And there may be some disordered eating in wrestlers, for example, that doesn't necessarily qualify as an eating disorder. And that's true of many athletes. But I will say this, athletes generally know a lot more about nutrition than would regular college students, for example. And so from that standpoint, they generally know what they're doing and would have a much higher idea of how their nutrition is affecting their performance. Here are some clinical markers for you to think about. If, for example, binging is an issue of throwing up your food, you're looking at twice a week for 3 months to be clinical, so that needs to be a fairly consistent pattern. For anorexia, women have to miss 3 menstrual cycles, so that's, again, 3 months. There's a refusal to maintain normal weight, and then an intense fear of gaining, even though you are underweight. And then in addition to that, you have some of these habits that are B, which occurs recurrent inappropriate binging, and then a perceived lack of ability to control that. So those will be clinical features that you would have to have some, and you'd see it has to be a pattern that occurs for at least 3 months. So if you had anyone that experienced this for a couple weeks or 3 weeks or a month and a half, they wouldn't really meet the clinical diagnosis of eating disorder, but they would have some disordered eating. Hope that makes sense. Now, in an interesting research study that was done in a college sport population, you can see here that about 6.4% of women on a college campus and 2.7% of men met the clinical markers for some type of eating disorder. And this was either anorexia or bulimia. And then another, about 1 out of 5 showed some sort of subclinical eating disorder, but no gender difference there, meaning they had some of the features. So the first thing to be aware of is women are about twice as likely to be clinically have an eating disorder. Now, if you look down at the athlete situation, and we just look at male athletes versus male non-athletes, they're about 1/3 as likely as male non-athletes, so 1.8 to 5.5. And female athletes are almost 1/2 as likely as female non-athletes. So the gender effect is still there, but you can see that the percentages of those who have clinical eating disorders is higher in the non-athlete population than the athlete population. So really trying to disprove that myth. Now, there's also the idea in sport that if you're from a lean sport, such as cross country, gymnastics, wrestling, where you have to show swimming, where you have to show more of your body, that those athletes are less likely to meet the criteria for an eating disorder. Whereas the common perception is that those sports would be more likely. Can you think of any reason why it might be less likely? Just take a minute and think about that. It refers really to the point I made previously, that those athletes in those sports are so knowledgeable about their bodies, about their nutrition, and how that relates to performance, that they're actually less likely to be at risk because of that level of education, and also because of the relationship between nutrition, body, and performance that athletes experience. So you can't be, at a high level of performance as a swimmer, for example, if you're not taking in calories. You'll simply be out of energy, and you won't be able to train and perform effectively. Whereas if you're just a regular college student, you could get by for several weeks on some ridiculous diet of 750 calories, which would be barely 1/3 of what someone might need. Whereas if you're trying to train and do that, it will be fairly quickly apparent that that's not a good idea. All right, let's transition on to some kind of non-clinical information. So for Athletes that are injured athletes that are not meeting any of these criteria, which will be the bulk of the athletes you work with, probably 90%, to help them with their mental health, their anxiety and depression, these are what you should focus on. Getting back to some form of physical activity that they can tolerate regardless of their injury. So if they have a lower extremity injury, they need to do something with their upper body. They could do hand ergometers. They could be doing some sort of other calisthenics as long as it's not disrupting. If they have an upper body injury, they could certainly be riding a bike or walking or doing whatever is prescribed by the doctor or the ATC. Staying engaged with the team and around friends so that if you need support, it's there. Continue along with regular class study habits, and then just take care of yourself physically and be even more rigorous about that. Make sure you're getting good sleep because you need that to recover. Just taking care of yourself, getting up and dressing, eating properly, all that stuff that we may not take as much time to do when we're not feeling as well. Let's take a few minutes now and transition to pain and pain management, which is another key issue here that I wouldn't say it's a clinical issue. I mean, basically 100% of injured athletes have to deal with pain. It's just a matter of are they dealing with the pain effectively or not, and what kind of experience do they have with pain. A lot of times, particularly if it's a first injury, athletes are used to experiencing training pain, soreness and fatigue, but injury pain is a little different, and we will transition and look at the different types of pain. Here's what happens to the body when you're under pain. It's on fire, the way I think of it. I mean, the body is signaling, help me, bring something down here. And the brain knows pretty quickly, based on the chemicals that occur, there'll be inflammation, there'll be pain. There's a don't walk on this is basically what your body tells you when you injure your ankle or you break your foot. Don't walk on this. And what does it do? It makes the equivalent of a cast on your foot. If you've ever had a sort of foot or any other injury where you break it or you have a severe sprain, your body, this is before athletic training was ever around, makes a cast, and it swells up, and it makes it very difficult for you to walk on it. Well, there's a reason for that, because the body does not want you to walk on it. It wants to try to repair it. So it creates its own casting mechanism, at least for that short period of time. Then you do need to get the swelling out. Now, pain is occurring there because it's a signal of injury, and to let you know, hey, don't use your foot. There can be tension and spasms that go along with that, and there's typically a constriction effect. So there's tension in that area, and there's swelling that will eventually need to be reduced or cooled off. That's why ice is often a very common intervention to help deal with pain, because it just cools everything off. There's a lot of heat applied within the body as that sympathetic nervous system gets cranking up. That's what SNS is there. From the psychological side, there can be a lot of anxiety or fear in dealing with that pain, and whether or not there's enough strength in the ligament, the joint, whatever it is that you're testing, the bone, and then there can be very irrational self-talk related to that. Two types of pain I referred to before was this issue of performance pain that may be due to a really tough session, a workout session, a strength and conditioning session that's under control of the athlete. So we look underneath that column there. The athlete's response might be they'd be very satisfied that they went through a really good workout. They have pride, and then next day there's an increase in performance. Now, unlike that, injury pain seems uncontrollable. It is a signal of damage. It doesn't really go away quickly, or the next day it's still there. And the self-talk in that area might be very self-defeating. Oh no, I don't know if I can deal with this. Oh, this really sucks. And there'll be fear and anxiety related to that pain response. So those are the two different types of pain and self-worth to athletes to differentiate between, hey, are you injured? Is this an injury? Or is this just something due to training? And helping them understand and educate about that. One of the most useful psychological approaches to pain management is called gait control theory. And so it suggests that we have some control over how much pain flows through our body in our general attitudes and behaviors towards pain. So we can open up the pain gate and let more pain in, or we can close it and choose to experience less. So it has to do with our thoughts, that's our self-talk, and then our actions. So the more confident or efficacious a person feels, the less pain they will subsequently experience. So let's look at what behaviors and thoughts might affect that. And we're going to focus on the positive coping angle. So we want to encourage positive thoughts that suggest to the athlete that they can manage this pain. Like, okay, there's something that I can do to make this better. Not Pollyanna, unrealistic stuff that would suggest that it's no problem, or I'm the master of pain, or something of that nature, or I love pain. Just that, okay, I can manage this pain. There's things that I can do to cool this off. Moderate activity refers to doing something, some rehab, some walking, some stretching, some activity that is appropriate. And almost all rehab protocols now for almost every injury include rehabilitation starting immediately, almost, or within 24 hours of the injury. And so this goes directly with current rehab protocols. This moderate activity will stimulate endorphins and monoamines, which are neurotransmitters, and it will help clear cortisol out of your system. So that cortisol is a stress hormone that is catabolic in nature, which is basically the opposite of an anabolic hormone, and you want that out of your system. It's a stress hormone, and the stress hormone is in your system when you believe that you cannot deal with something, or you are under imminent stress or danger. So that's the difference in the attitude. When you're having catastrophic thoughts and you're very fearful, you'll have a lot of cortisol in your system because your body thinks you're under threat and you need to go out and do repairs. Okay, instead of being just active and an active patient. So in this case, you're able to manage stress, and it's a moderation approach as opposed to an all or none approach. So those positive coping behaviors really refer to the attitude and the general behaviors towards pain and rehab that will help athletes manage their pain and feel somewhat in control of it. So with pain management, some of the big tasks for us in sports psychology is to help athletes monitor pain, deal with their thoughts and their behavior, help educate athletes on what we talked about before between performance pain and injury pain, and then learn pain reducing and coping techniques, which we'll be dealing with in a later unit in this course. We'll be dealing with the relaxation imagery stuff down in Unit 4. Along with those big tasks, help them figure out what they can do to feel in control of their progress. And the basic message we're trying to send is this will get better. So it may not be great now, it may not be manageable now. You do want to give them some tools that are possibly pharmacological in nature, and then also non-pharmacological issues. And the message is this pain will get better and you can deal with this. And so whatever way you need to phrase that or get that across to them, help them get to that point, then that's what you got to do. There's a note here to avoid malingering. It can be important to ignore negative pain behaviors that may be attention seeking, particularly for pain that cannot be verified through an MD or for an ATC. So sometimes pain can just be made up to avoid other things, and we have to be careful that it is actually pain related to the injury. And then if they have chronic pain issues, then referral will come into play, and we're going to look at some of the steps of the referral process here at the end of this particular unit. Any young professional, whether you're in sports psych or you're in athletic training or coaching, it's important to understand what your limits of your expertise are. So as a certified coach or a certified athletic trainer, you are certainly competent at a baseline level to do a lot of different things. But you may feel as certain questions come up that it's not really your area to treat. And so here's a few steps that you can ensure that you'll have the proper support to deal with psychological issues, for that 1 in 10 athletes or that 1 in 20. Again, we're talking about a 1 in 10 situation that an athlete might need a referral. But it's good to have that set up so that when it occurs, it's already in place. The first step to this is of course, having somebody to which you can refer. So you might, I always talk to athlete trainers about kind of the next job. Here at the university, at WVU, we have access to excellent support networks. Dr. Etzel is a psychologist on staff. All students, whether you're a student athlete or not, has access to Caruth Center for Counseling and Psychological Services for free. So here at the university, we have a very good setup, and all you would need to know would be the numbers and the hours of those places, so if you need to deal with that, and where Dr. Etzel's office was, etc. Now, if you're working somewhere else, or when you get your first job, you might want to find out about that from the ground up. Who are they? Have they worked with athletes? What their certifications are? Hopefully in SEP 272, you got some overview of the training requirements and ASP certification and licensure, so that you understand, is this person a competent psychologist or counselor? And then if they work with athletes, that's really just a bonus. Okay. Steps. If you're unsure, the first thing to do would be talk to the psychology professional. So call me up, call Dr. Etzel, and in a confidential way say, hey, I have this athlete and here's the situation. What do you think? Should they be referred or not? After you've done that and you have a feeling, yeah, okay, I think I'll make a referral, then you talk to the athlete. Here the athlete say, you say, Larry, you seem pretty depressed, and I think it might be useful for you to talk to someone about it. It's getting in the way of what we're doing here, and I don't know if I'm the person to help you with that. And then, hey, I had an athlete with similar concerns last year, and he found it helpful to talk to Dr. Psycho. Hopefully your referral is not Dr. Psycho, but you get the idea. So the issue is you talk to the athlete about it, and then you explain why the referral is being made. And you say, you know what, my job as the ATC is really to design the rehab, monitor it, help you evaluate that, and and yes, to motivate you, but I think this stuff is getting in the way, so someone else is better equipped to help you do this. You then maybe want to deal with, well, here's what would happen if you went and met with Dr. Psycho or whomever else. They're going to talk to you one-on-one, just like if you met with a coach, a faculty member. They're going to sit down with you on an even level and try to understand what it is you're struggling with. You may need to address the stigma of psychology there. Some people have that, and certainly if you have that as a coach or an ATC or a sports psych student, then you really need to get rid of that if you're going to be successful at making referrals. Because really what happens in counseling is not that different between a discussion between two individuals, and it's a joint relationship meant to help and guide the athlete. So you let the athlete ask some questions and see if they have any concerns about seeking help. And then if necessary, you get written consent to share information. So then you can call up Dr. Psycho again and say, okay, Larry's going to come out. Here's what he's dealing with. Here's what I have observed within our relationship, and here's what you give some background information. And then, of course, whoever you send them to will have a screening interview that they go through with that. So you can either make the appointment or you can give the athlete the information, depending on your approach and how imminent you think you need to do that. A lot of times I'll call them for the athlete if I have them in my office, and then I'll just have them set up the appointment. Then I might follow up in a week or so to see if the athlete went, and then I really don't bother them anymore in that area. I might follow up once or twice, and if it's really their choice. You cannot make people go seek out that help. Be patient, raise it maybe one other time. It's their responsibility. You've done your job. And then if you can just document whatever notes you're taking for cover your butt purposes, there's also a good step-by-step guide in your Ray and Weiss Bjornstall textbook on this topic as well. Okay? So hopefully that material will help you make a successful referral. For this particular unit, you do have another reading quiz that you'll need to complete by July 16th. You have a reading reaction that's a discussion thread in this case, and you're asked to read either the chapter written by Etzel et al. Or the Fisher and Risberg article and do a reading reaction to that. And then I encourage you also to read some of your classmates' reactions to see what they're thinking about it. There's a case study out of the textbook as well, and that is a written assignment that you will submit in Word form. So hopefully these assignments are making sense, and I'm sure you're in the rhythm of the class by now. And as always, drop me an email if you have any other questions. Enjoy the rest of your day.